So, Doctor, there's been a new announcement. The CMS has announced on 19th March the ACO Primary Care Flex model, which is a voluntary model that will focus on primary care delivery in the Medicare Shared Savings Program. And with its main focus being that it aims to increase the number of low revenue ACOs in the Shared Savings Program. So, keeping that in mind, the first question that I have with you is how do you anticipate the ACO Primary Care Flex, ACO PC Flex model will specifically empower revenue ACOs, particularly those predominantly owned by physicians and with the focus on FQHC and RHC services?
I think that what we're seeing, and not just this program, but I think what we're seeing overall are a lot of different opportunities and ways to participate in risk-bearing contracts. And I know that there is this desire that everyone will participate in a risk-bearing program by 2030. And I think that this is another attempt at that. I think that it's in reading through the document, I think that sometimes things look good in theory, but the how they'll play out may be challenging. I think that there's some benefits. I think that in the program, CMS is trying to get creative in looking at who patients are and in rewarding them or rewarding those PCP practices for the work that they're doing. But I think that, and to the point that I said about, it appearing to be more theoretical, I think that there's some challenges. And I was reading through the analysis that NACOs did and some of the commentary, and then just reading through the CMS documents myself. And I do have some concerns. And so, looking at the model, one thing is that once a practice is considered to be high performing, it gets moved into assuming more risk. And I think that that can be problematic because a lot of it is relying on data, and they tend to take the year prior of data, and it's a pretty fast moving analysis. So knowing that, from year to year, you could be changing as far as your level of participation. We know in the industry that data is a challenge. And so I think that if you are not set up to capture your expenditure, which is what it's looking at. So it almost has, I don't know, I'm not a math person, but it almost has this flipped MLR. And so what they're looking at is revenue over expenditures, and then using that as a way to identify those practices that are high revenue versus low. And, just thinking that we don't do a great job at capturing that today. I mean, even in like the Medicare Advantage space where data is so critical. And I think that a lot of folks have invested heavily in trying to get that right. I think it's even harder on the Medicare fee for service side. And also too, just thinking about, we in Medicare Advantage outperform in coding trend. I mean, even if you look at the final rule that just came out on 2025, the CMS comments that, things can be made up in coding trend. And so with that statement, knowing that typically in that Medicare fee for service space and in this MSSP space, that coding tends to be challenged. And so I think that for those that would be successful, and that was the thing too, is that they're estimating that the majority of participants that would be on that low revenue side, that it would be primary care, and then for the high revenue side would be hospitals. But I think that you would really have to do an honest assessment to ensure that you are prepared to participate in this program. And that's the thing. You have to make a decision. I think the beginning period for applications is coming up, right? It's May 20th. It's a short window. but you would really need to do a very good, diligent assessment of where your organization is. And then just knowing that if you are deemed to be high revenue, and that could be, like I said, I think the depiction could be questionable, depending on what your data is. And then just knowing that you could be thrown into, that risk program is challenging. There's some benefits too. CMS talks about providing some advanced payments, which I think is important, not having to wait for the revenue. And it gives you an opportunity to shore up and ensure that your organization is ready. But I think that even with that, it's a flat-based fee is what I had read. And so I think that it may not be enough. So I think that there are some positives. I think that they've made some great strides in being very creative. I think that there's some challenges with it still being quite theoretical, and that it will play out differently. And then knowing too that there were some areas where they didn't push, right, and didn't maybe strive to be as creative, and adopted just some basic things like that straight payment, as far as for monies to provide to shore up your systems. And I think that those are the types of things that would be challenging. So it'll be interesting to see. I would imagine that there may be some revision after the first year of participation, knowing what we saw in ACO Reach. But again, I think that there's a lot of new programs out there, and so it'll be interesting not only to see who gets to come play right in the space and participate, what the outcomes are, but then also too, how that then influences the ripple effect into the rest of the industry.
Thank you so much for that. And I do agree that this is going to have a very significant impact on the industry as well. And with that, my second question is, given the emphasis on primary care in the ACO primary care flex model, how do you envision the participation of small ACOs influencing care coordination and patient outcomes, especially considering their ownership structure and patient demographic focus?
Yeah, that's the theoretical part, right? I think it's fantastic. I think that there's no better level to influence patient care than primary care. And so knowing that you have physicians contributing and commenting then on the care of those patients, and that's what it's about. When I think about ACOs and value-based care, it's really about documenting the patient's condition, right, is a key piece, but also too then managing that condition. And so everything around what are you doing to ensure patients are seen or getting the right care at the right time in the right form, right, at the right price, and so on and so forth, as well as ensuring that they're taking adequate steps with their preventative care, and that they're getting their screenings and things like that. So I think that it's a great opportunity for PCPs to participate. And I think, one of the things that I've heard for several years now is just the burnout factor. And I think feeling like that they could make a difference. I mean, when I talk to most physicians, they went to medical school because they truly are called to care for patients, right? And to make people feel better. And so I feel like in this type of program, they're rewarded for that. And so I'm excited for that, for that ability and for their ability to affect that. But the only thing, and I think is the cautionary tale, for me anyway, having worked with provider groups for a long, long time, is making sure that their systems are set up appropriately, and that they're capturing all the good work that they're doing in a way that then provides that report. And so it's very different than how folks maybe have operated in the past. we know that even in like I had shared, even in Medicare Advantage, that there's opportunity to be better at capturing that data. And so I can only imagine knowing and looking at the rates that come through on straight Medicare, that, there's a lot of opportunity there.